We're on the chapter over the lymphatic system, which is our drainage or overflow system for that increase in interstitial fluid because of capillary dynamics. Remember, we have to get that fluid around the cells in order to feed them and to remove waste. And to do that, the fluid has to leave the capillary on the arterial end and must come back on the venular end. But we do not get that total number returning. We get a smaller number returning. So we have this interstitial excess or overflow, which is commonly called edema, if it is not relieved. And it is relieved by our lymphatics, and more specifically by our lymphatic capillaries, which interweave in the capillary beds of our tissues. We need to make a quick little diagram of this process. And this is meant to be a short area through a capillary bed, A for arterial end, V for venular end. And so if we talk a little bit more about the total pressures, remember our capillary hydrostatic pressure on the arterial end is 35, right? And we have a hydrostatic pressure of our interstitium is 0, so that's why the net is still 35, and that's why we can use our capillary hydrostatic pressure. And so pushing the fluid out is counteracted by pulling the fluid in. Hydrostatic pushes out, osmotic pulls in. And our net osmotic pressure for this area is 20. And it actually is the net osmotic pressure for both ends. So we have then a net fluid loss of 15 millimeters of mercury, and that is going to go out into our interstitium. So that's going to carry the nutrients and good stuff that we actually need to feed our interstitial fluid. But when we get on the venular end, remember our capillary hydrostatic pressure on the venular end is 15, and we can still just use that number because our hydrostatic pressure in the interstitium is 0, because it would be a net, and 15 minus 0 is still 15. Now, when we subtract our net osmotic pressure, which we have already discussed is the same on both ends, of 20, that gives us a number of -5. What does that -5 mean to you guys now as you answer that last question and are preparing for the upcoming exam? Which way is the fluid moving? In. So that means that we had 15 out here in the interstitium, and we are taking 5 back in. And that's what gives us our -5. So we have a deficit here. We have a deficit of 10, correct? And so we have 10 millimeters of mercury worth of fluid accumulating in the interstitium, which would make you think that we have hydrostatic pressure in the interstitium. But that is not the case because we have lymphatic capillaries. And so our lymphatic capillaries are going to be found also interwoven among our cells of whatever tissue we are. And so we're going to find them snaking through and draining those interstitial spaces. And the difference in their construction is quite remarkable from our continuous capillaries, in that the cells overlap instead of our tight junctions, which we're used to discussing with our regular capillaries, because these are lymphatic capillaries that I'm drawing here. We're going to make some overlaps. So I draw them on the outside of my vessel instead of the inside. And these are all just endothelial cells with this overlapping structure, which creates almost like a pseudo valve type of situation. And the reason they are pseudo valves is because in between the cells, their little overlap area of the endothelial cells and the interstitial cells, we have a little bit of CT attached to the overlap. So if it's attached to the overlap and we start to swell up with fluid, we end up pulling on that connection, pulling it that way, and then this fluid we'll say 10 on this side, then this fluid can't enter into the lymphatics via that mechanism. And that's how the overflow into our interstitial spaces is drained off. So our lymphatic capillaries are overflow or drainage capillaries. And this is well known in anybody who's had a lymph node dissection for the removal of breast cancer, because then we've interfered with the network of our lymphatics and we have interfered with the return of the interstitial fluid, and they end up with a condition called lymphedema. And so obviously the interstitial spaces will have a higher hydrostatic pressure, which is the only mechanism to try and get the fluid actually back into the capillary bed. Still, the tissues themselves are quite swollen. So lymphatics have this hierarchy of structure: lymphatic capillaries, lymphatic vessels, lymphatic trunks, and then lymphatic ducts. And there's only two of our lymphatic ducts. We have the right and the left. The right services the right head and upper extremity. The left services the left head, upper extremity, and the rest of your body. And that is because, we don't know why, but it is just what it is. If we look, if we look back here at this cartoon picture, this is showing you the right, and this is showing you the left. And it is showing you the nice green thing that's coming up the thorax, which is also the thoracic duct, also referred to as the left lymphatic duct, is draining everything from down below, in addition to things from up above. So we actually have these feeders here and here on the right. I've got things in the way over here. We'll open it up. We have additional feeders, which would be trunks coming into, which is our left duct, which is then emptying back into our circulation here at the internal jugular subclavian junction on the left. And on the right, we just have very little actually entering into the internal jugular and subclavian junction on the right side. When we look down below the diaphragm, there's this important structure, cisterna chyli. A cistern is a device that's used, or a receptacle that's used to collect water. Well, so this is cisterna, a device or an area that collects chyli, or basically Latin for the lymph fluid itself. So that's immediately under our diaphragm, and it is like a lake. And a lake has many different tributaries to it. And so we have our trunks, which are tributaries to it. And so we have trunks coming in here. And trunks are called, have given names because they're large enough to identify. And so we have some lumbar trunks, 2 of them, and we have a single intestinal trunk. They are all taking lymph from the intestines, obviously, and from everything on the back side, including your legs, up into this cisterna chyli. And then lymph is going to continue to move upward so that it can get back into the circulatory system. We lost fluid on the venous side of our capillary bed, correct? We end up putting that lost fluid into the venous side of our return system. It's just closer to the heart. And so that's another interesting aspect of this. We lost a little fluid, but we're still putting it back in, and we're putting it back in even on the same side that we actually lost it. It's important to realize our lymph transport is very similar to our venous return. Our notes here say there's rhythmical contraction of lymph vessel walls. Well, that's minor. It's very weak, because these are thinner walls than veins. And veins are easily ripped or torn or penetrated, and these are even thinner. So this is a minor way to get lymph back into the system. The major way to get lymph back in is via the same factors of our venous return. The muscular pump, well, we're talking about skeletal muscles when we refer to the muscular pump. When we talk about the ventilatory or respiratory pump, we're actually talking about changing intra-abdominal and intrathoracic pressures to help milk that back, because they have even more valves in them than our veins do. So our lymphatics have tons more valves than veins, and the valves start at the lymphatic vessels, blood vessels, not blood vessels, but lymphatic vessels. So The lymphatic system is an interesting system because lots of fluid can be returned via this system. In addition, this will help to drain areas that are undergoing osmotic changes. And so if you have a bacterial infection, what do you suppose happens to particles in the interstitial fluid? Do they get less or do they get more? More. And so that increases osmotic pressure of the interstitial fluid, which remember is pulling fluid in out of the capillaries into the interstitium, which will then drain into the lymphatics. And so that's why the lymphatics are such also a great mechanism for getting stuff, because we can get big stuff into lymphatics because they aren't like our fenestrated or continuous capillaries or even like our sinusoidal capillaries. They allow for a large amount of material, fluid and other things to actually enter. And so hanging lymph nodes off of this is going to be very helpful because lymph nodes are filtration devices. And that's the way we actually need to take a look at them, as filtration devices. So hundreds distributed throughout the body. We have concentrations. In cervical, inguinal, and axillary. I should have put axillary first, but that's all right. We have large concentrations in those areas that we are aware of. Lots of concentrations of lymph nodes also associated with the intestinal tract, but the ones that we are aware of are the cervical, inguinal, and axillary ones because those are the ones that can swell up and become tender. And so we are aware of those. They are sites, or lymph nodes are sites of filtration of lymph and immune system activation. These lymph nodes are full of lymphocytes. That's how they got their name. Lymphoid tissue, lymph and lymphocytes. So you have to understand interstitial fluid is what color ordinarily? What do you think interstitial fluid color is? Clear. What do you think ordinary lymph color is? Clear. And so whenever lymph is no longer clear, that is an indicator that it's actually bringing other things along with it to the areas. And so you want to, it's called lymph because of more or less the lymph nodes, which are full of lymphocytes. And that's part of the immune system surveillance. This is a nice picture. It does a much better job of showing you the overlapping valvular system of our lymphatic capillaries, which helps to bring lymph back up towards the heart. Let's take a look at the structure of a lymph node. And like all organs do, we have a nice capsule. It's dense, irregular fibrous connective tissue. However, it's kind of strange in that it is loosely attached. And that is actually for a reason. We actually want to have space underneath that capsule. We have the stroma, which is the basic tissue of a lymph node, is actually held together by reticular fibers, which remember are collagen fibers that are thin and lacy-like or branching, and they are designed to loosely hold things together. We will find reticular fibers in all of our lymphoid organs, besides lymph nodes, except the thymus. There is no reticular fibers in our thymus. The outer aspect of a lymph node is the cortex. The inner aspect is the medullary area. So here's our medullary area for that. Before we draw our follicle, there it is, inner core. And in the outer aspect of the cortex are these nodules. We call them lymphatic nodules. They can also be called follicles, so sometimes you'll see that in some of the literature. But they're basically circular. Well, here's a nice one over here. They're basically circular. We have a dark perimeter and then we have a lighter central area. The lighter central area is called the germinal center. And it's called germinal center for a reason, because the word germinates means something's growing. And in the germinal center of our lymph nodes, that's where we definitely find B cells. B cells are a specific type of lymphocyte. Those are guaranteed inside the germinal center. We'll have T cells and some B cells in that mantle zone area, but also macrophages. We'll get into that in the notes. When you take a look at a histology view of our lymphoid tissue, what you are supposed to be doing is trying to say, how can I recognize this, A, as lymphoid tissue, and then B, which type of lymphoid tissue? So right off the bat, we see a cortical area full of these nodules or follicles. They all have a nice darker outer aspect and a paler inner aspect as far as the staining goes. And then we have our nice medullary area, which is full of sinusoidal arrangements. And remember, sinusoids are those leaky areas where we can pull things out or put things into that liquid that's actually inside those sinusoidal areas. This term trabecula is just an invagination of our capsule, and so you'll see it branching on in, trabeculae carneae. It's a trabeculated type of a pattern for that. And one of the things too about the capsule, I want you to take a look, I'll erase now. I want you to take a look at how loosely it is attached in this picture. And that is because we actually want the lymph that is draining into the lymph node to also be able to accumulate in the outer aspects and then move or percolate into the inner aspects, the medullary area, before it actually leaves. So if we were to diagram our own follicle, we'd have a nice outer dark center and an inner center that's full of our B lymphocytes. So this is B cells, the mantle, T cells, and the B cells are dividing. So we're actually growing B cells, and the only reason they divide if they have been activated. B lymphocytes, as our notes say, predominate in the germinal center. T lymphocytes found in the rest of the cortex, obviously concentrated at the perimeter of our germinal centers. And then dendritic cells are another cell that we have talked about just briefly when we were talking about the skin. Dendritic cells are specialized macrophages. And they are involved in activating the immune system. With our lymph nodes, we have more afferents than we do efferents, and so the afferents are actually coming into, should be actually a diagram of a lymph node. Taking a look up here, here are some afferents. You can see the valves even in these very small lymphatic vessels, all bringing lymph into the subcapsular sinus area. So that's why it's loosely applied. It flows into that area first, and then will start to flow in through the remainder of the lymph node towards the medullary area. And from the medullary area, it will flow out the efferents, which they're typical, very, very few, 1 or 2. When you have more flowing in, because you have more channels in, and therefore less flowing out, this causes a stagnation in the lymph node, correct? And if you have increased lymphatic flow, the lymph nodes will actually kind of swell up because they're actually designed for swelling. Another reason for less tight capsule applied to them. But this allows for stagnation of the lymph fluid in the lymph node so that we can slowly percolate that lymph fluid towards the hilar area, which is the little indentation of our little bean here. And then after we've got it all collected in the hilar region, it will flow out via the efferents. So this system is designed to maximize contact of lymphatic fluid with the contents of the lymph node. And the lymph node is full of lymphocytes. And lymphocytes are key players in the immune system. So lymph nodes are very, very important sites for bringing the bad stuff to. If you want to have an immune response, you need to take the bad material to the cells that are going to mount the immune response. And the cells that help us mount our immune response are lymphocytes, T and B lymphocytes. So this process is actually very effective and very reasonable. So afferent vessels are going to conduct lymph to subcapsular sinus area. Then that lymph is going to slowly percolate throughout the lymph node. To where it actually can get to the efferent vessels at the hila. So we have nice slow drainage because of our definite lesser number of efferents. Lymph nodes are not actually our primary lymphoid organs, and we'll talk about what our primary lymphoid organs are in just a moment. Primary lymphoid organs are indications where lymphocytes are born, where they actually come from. So the lymph nodes are not primary lymphoid organs, they're actually considered secondary lymphoid organs, and so is the spleen. The spleen is our largest lymphoid organ. It is located under your diaphragm to your left behind your stomach. It is serviced by an artery and a vein. So it's getting blood instead of lymph, correct? Yet this is a lymphoid organ. Why do we want to have a lymphoid organ hooked into the bloodstream? You can have bad stuff in the bloodstream, correct? And so remember, these lymphoid organs are designed to be a surveillance system and activation and to respond and help to eradicate the bad stuff that's in the soft tissues, which will be lymph, or in your bloodstream. So the spleen is an important lymphoid organ to actually surveil your blood to make sure that we don't have bad stuff or stuff we don't need actually there. And so that's why it states here, filters vascular debris, dead cells. We're having dead white blood cells, we're having defective red blood cells, and that's the spleen's, one of the spleen's very important jobs. It filters out those bad things, but then also filters out pathogens that are actually in the bloodstream. And typically we think of bacterial pathogens for that. Because it's a lymphoid organ, this is where we actually have lymphocyte activation and then proliferation. Because they don't proliferate, they don't undergo mitosis unless you need more of them. And you don't need more of them unless you actually activate them. And so that's why in our notes it says immune surveillance, which would be activation, and response, which would be the proliferation. Previously mentioned recycling of red blood cells. The spleen is very important for removing our defective red blood cells, beginning the recycling process, and sending the their materials from recycling to the liver for proper processing. The spleen also is a great area for storing iron, so that's a nice thing about the spleen. And it is an absolute fantastic blood reservoir. So it's full of blood cells and full of platelets. So if you're having a hemorrhage, it's a really good idea to have a little bit of a backup system, and that's a little bit what the spleen is for. If you have hemorrhage, the spleen will literally cause itself to contract and give a little extra bolus of blood and platelets, which are obviously an important part of hemostasis. When you take a look at the spleen and you compare it to the histology picture of the lymph node, it should look very different to you. There's our spleen and there's our lymph node. The lymph node is under a lower power view, but there is a similarity there. We actually see something that looks like a nodule. We don't call it a nodule in the spleen because it's not in the cortical areas. Those nodules that you see there, or what look like nodules, are throughout the spleen itself. And we call that area white pulp. It doesn't look white on the smear and stain, but it looks white in real life. And we call the other stuff red pulp. And you can guess why they call it red pulp. It's called red pulp because it's full of blood, red blood cells. And they call the other white pulp because it's got the other cell that's important in lymphoid tissue. It's lymphocytes. And so what you see here is you see a bunch of nuclei. And remember, lymphocytes are predominantly look like a bunch of nuclei. When you take a look at them, they only have a sliver of cytoplasm. And so you have that really dark collection that you wouldn't want to call white pulp unless you think about it and realize those are lymphocyte white blood cells, and that's what nuclei look like. They look like a purple bluish stain, and you have a whole bunch of them close together, and that's what we actually see. Our red pulp is venous sinuses, got the red blood cells, got platelets. We do have B cells hanging out, but not concentrated in our red pulp, and macrophages there. But in our white pulp, we have T and B lymphocytes, in addition to macrophages. So macrophages, remember, they're phagocytes that are taking out, they're taking foreign material, they're ingesting it, creating their own phagolysosomes to digest the materials so that it's not harmful to you. We see again trabecula as part of the spleen structure, and it does have a capsule. This capsule is more adherent, more tightly attached because the spleen is not supposed to really swell up. It can under certain unfortunate blood cancer related conditions, but that's not a usual trait. So the capsule is adherent but fragile. It is the thinnest capsules of all of our lymphoid organs. One of the things about the red pulp, this is where our macrophage recycling actually occurs with our red blood cells. And the white pulp is where our immune system activation occurs, if needed. As far as blood flow, we actually have blood coming into the spleen via the splenic artery. A for artery, and then it will go into the white pulp. And then go into your red pulp. And then out via the splenic vein. Have you guys ever heard of people having their spleen removed? And the reason their spleen is typically removed is because of trauma. Because the spleen is hooked into your circulatory system When it gets traumatized and its capsule is very thin, then you've got like a big gaping hole in your spleen and it's going to bleed on out. And so they do splenectomies because of trauma to the spleen. Even though it's back there behind your stomach, kind of tucked underneath your ribs, it's still very susceptible to trauma. When they remove the spleen, the person's immune system is not compromised because the liver takes over many of the splenic functions. And so the liver can only do so much. It cannot do the immune surveillance. And so it's kind of interesting. People who have splenectomies, they actually end up, even at a young age, getting vaccines that typically older people get because their spleen is no longer there to help actually take out pathogens. The pneumococcal vaccine is an example of a vaccine that anybody with a splenectomy gets as soon as they get a splenectomy because they need that help in actually eradicating that bacterial pathogen from their system that the spleen no longer can do for them. Now the thymus. The thymus is a primary lymphoid organ. It is the site of our T cell differentiation and maturation. So let's talk about T cells and B cells for just a moment before we get into more about the thymic stuff. Where do all of our blood cells come from in us? Where do they originate? Where are they born? Where's mitosis occurring? Bone marrow. So it's in the red bone marrow. And so our lymphocytes are no different. So all red blood cells, white blood cells, lymphocytes, and platelets all come from our bone marrow. The difference between T and B lymphocytes is that we call the lymphocytes from the bone marrow that do not go to the thymus for their training, we call those B lymphocytes. So B lymphocytes are called B lymphocytes because they do not go to the thymus. So we have the two lymphocyte line, T cells and B cells. So all lymphocytes will eventually either go into one category, a T cell or a B cell. If you don't go to the thymus, you finish your training and indoctrination, so to speak, in the bone marrow, and the T lymphocytes get taken to the thymus and then get trained and indoctrinated into the thymus. And the thymus is a very important immune system organ. And it actually atrophies as we age, which also shows why we're more susceptible to other infections and cancer and processes as we age than we are when we are young. So it's a really big organ when we are young. And it has to be a big organ because when you are born, you went from a nice sterile environment out into an environment full of germs. And your thymus is very important in actually taking care of you, making sure that you do not succumb to the world that you have actually been born into. Our notes here say the thymus lies deep to the sternum, and indeed, it is between the sternum and the heart, and it's more on what I call the superior portion of our heart. And the thymus is glandular, and as it atrophies, the glandular material turns into fat and connective tissue. So let's go ahead and add a little bit of that to our notes. So active when young, so glandular, overlying, superior pericardial sac, atrophies as we age. It's very generous when you're born. It's huge. An x-ray, you can even actually tell where the thymus is located on a plain x-ray of a newborn. Atrophies as we age into fat plus CT. Atrophy begins after puberty. Primary lymphoid organ, site of T cell differentiation and maturation. So where your T cells come from, they all come from the thymus. The thymus is important because it is going to actually help to allow self to recognize self. Sight of self-recognition. This is important to prevent autoimmune problems. So T cells go in. So in other words, will you find a B cell in the thymus? No. No B cells there. Only T cells, and they reject actually the majority of cells that come in. So only the cells that are actually able to recognize self as self are actually trained and released into the bloodstream. So it's a very important aspect there. We have no follicles in here because we have no B cells and germinal centers. We do have a cortex, which is the outer darker area by the stain, and that is immature T cells there. In the medullary area, which is the lighter area, based upon our stain, is where you find the mature T cells. Prevents autoimmunity. The other thing about this, in order to train the cells to recognize self, you only want self there. And so foreign materials are actually not allowed entry into the thymus. So there is that kind of thymic blood barrier. Just like the blood-brain barrier, there's also our thymic blood barrier. The blood-brain barrier was to minimize nasty stuff getting to your neurons and the support cells, just the good stuff there, and so we actually have just the supply to the thymus, the nutrients that are actually needed by the cells in order to do their job. Again, active when young, atrophies into puberty and later. There is still some thymic function even as we are aging and become aged. Your cats, you can actually tell the age of your cats by the amount of thymus present. If you have a young cat, it will actually have a fair amount of thymic tissue overlying its heart. If you have a more aged cat, you will actually have very little thymic tissue overlying its heart. So you can actually even age your cats based upon the amount of thymic tissue present underneath that sternum that you actually removed the other week. So that's the thymus, and take a look at it and take a look at the spleen, and to me they look very different, and that's part of what histology is all about. Histology is all about, can you tell the difference between these two, and so therefore what makes this a spleen and what makes this thymus. The other primary lymphoid organ therefore is called your bone marrow. Thymus is primary lymphoid and bone marrow is also primary lymphoid. All the others are secondary lymphoid organs. And the last two that we're going to talk about are your tonsils. Those are lymphoid tissue associated with the pharynx, nasopharynx, and oropharynx, and Peyer's patches. So we have lymphatic tissue at the back of the nasopharynx, and so we call that lymphatic tissue pharyngeal tonsillar tissue. We have lymphatic tissue back at the back of the oropharynx associated there with our soft palate, and so we call that lymphatic tissue palatine tonsils. And lymphatic tissue that you very rarely ever see are also at the base or the very back of your tongue, and that's lingual tonsillar tissue. Now, I don't have a very high magnification on this, but let's first talk about what is the covering of tonsillar material. What kind of capsule will they actually have? Because we have capsules with this tissue too. What kind of covering will be associated in these areas? Stratified squamous epithelium. So that's what makes their capsule very different from other capsules, is because this is tonsillar, this is lymphoid tissue with exposure to the outside world, correct? So we have stratified squamous epithelium as part of their capsule, but we have an incomplete capsule with our tonsils because our tonsils aren't hanging out there all by themselves, are they? They're embedded in the soft tissue. So we have an incomplete capsule, but the portion that is capsular is stratified squamous epithelium. So that's one of the things to actually realize with this. When you look at them, you can still see the nodules when you actually start to increase your magnification. So see that dark rim and that lighter center? And so we have germinal centers here. We have the typical lymphatic nodular follicle here. So darker staining capsule or nodular perimeter, and then a lighter staining germinal center. Same cells are in the germinal center that we actually talked about. So when you hear germinal centers, that's always a B cell hot zone. So we have our T cells and B cells and macrophages all throughout our tonsillar tissue. But the tonsils also have another interesting feature that makes them good and bad. It has crypts or invaginations. So these tonsillar crypts are invaginations. Because tonsils are designed to trap pathogens entering into your system via the air or the food. And because of this interesting invagination pattern, you have to realize it's part of the good and part of the bad aspect of tonsils. Because what it means is stuff going over the tonsil material that could be bad for you can actually go into the crypts. So they can actually fall into the crypts, which will then allow us, because of the invaginations, to actually allow us to get into the tonsillar material tissue to get an immune response, which is tonsillitis kind of a thing. But what's lining the crypt? So what's lining the invagination? Stratified squamous epithelium. And what does stratified squamous epithelium always do? We always slough it. So if you have an invagination, this is part of what makes tonsils bad and good. If you have an invagination, that's where we can get the bad stuff in, and then we can get that little fester in contact with the surrounding lymphoid tissue, because stratified squamous epithelium also keeps it out from the lymphoid tissue, correct? So we have to get it into contact with our lymphoid tissue, so those crypts are designed for that. But the problem is, when they go down into the crypts, we always get continuous sloughing, which plugs up the crypts, correct? Plugging up the crypts with a little focus of infection in there can enhance access to our lymphoid tissue to get rid of the stuff, but also it's walled off in a certain aspect, and it can actually create a huge bacterial focus. You guys follow me with that? And then that focus can proliferate and spread and take over and infect the tonsillar tissue. And so that's one of the construction flaws of tonsils. And that's why we can remove them, correct? Because we have them removed because they have a tendency to remain chronically infected because of the crypts. So you get the stuff in the crypts, you create a plug to keep them in there, but you also can't get the stuff out of the crypts. And that creates chronic tonsillitis and recurring infections that you can't ever get to because they're kind of walled off with that epithelial arrangement for them. And so you can easily get tonsillectomies because of that. So the crypts are an interesting feature that contributes to the good and the bad of our tonsils. Again, palatine tonsils, either side at the posterior end of the oral cavity. They are the largest and most easily removed. Complications for them are usually vascular because they, remember, the soft tissue is going to be the vascular area that's going to supply them nutrients. Most easily removed because they are also the most easily infected. Lingual at the base of the tongue, rare to ever encounter those visually. And then pharyngeal, we also refer to our pharyngeal tonsils as adenoids because they are on the posterior wall of the nasopharynx. And when those tonsils get enlarged, there's a very specific symptom people will actually suddenly start to have when their adenoids or their pharyngeal tonsils are enlarged. You guys know? At back of the nasopharynx, snoring, absolutely. Snoring is a definite manifestation of enlarged pharyngeal tonsils or adenoids. And so those are often also removed when somebody gets their palatine tonsils, especially if some of the symptoms reported are that there's actually snoring as well as recurrent infections and need for antibiotics. Peyer's patches. They're calling them a different name now, MALT in the books, because they're it's localized accumulations of lymphoid nodules or lymphoid tissue. We'll still call them Peyer's patches, but realize when you see MALT, that's talking about these guys spread out in more than just this one area. So lymphoid follicles, structurally similar to tonsils, germinal center, which is where our B cells, and an outer mantle of T cells, B cells, and macrophages. And so the stuff over here where you see the P, you can still see these are lymph nodules all throughout this. And this is important because we have these Peyer patches located in the distal wall of our ileum. Do you guys know what the ileum is part of? Part of our small intestine, correct? So this is the terminus. The ileum will terminate into the cecum. And so if you just draw your large intestine first, ascending, transverse, descending, and sigmoid colon, all terminating into the rectum and anus. Big old bulging cecum, which is where the appendix lays off and extends from. And then here is our ileum literally T-boning into our cecum. And I'll just make a couple squiggles. And there's a little sphincter here. And we have Peyer's patches located in the distal wall of our ileum. In other words, where it terminates and joins in with the large intestine or the cecum. And there's this valve called the ileocecal valve. I prefer sphincter. That is responsible for allowing contents from the small intestine into the large intestine. Do you suppose that this sphincter, because that's actually what it is, it's not a valve like our semilunar valves or AV valves, do you suppose that this sphincter allows for only one-way transit? Do you think it's completely efficient with one-way transit of material? You don't think there's a little bleed over from stuff in the large intestine into the small intestine? Because what's in our large intestine? Yeah, it's poo, also called fecal material, which is a bunch of bacterial containing material. And so what's really interesting, all the stuff that's in the small intestine has undergone all kinds of digestive processes, which will make it a very rather sterile environment. You guys follow that? So it's a rather sterile environment in our small intestine until we get to where we actually empty into the large intestine. And that area therefore needs to have some helpers to make sure that any backflush or backwash does not actually penetrate or cause problems in that area. So that's the end of that chapter, and we will be on the immune system next time.